All right, everyone. Sorry about that. I hit the button too quick, so let's scroll down and we will continue on talking about the governance of hospitals. So we left off with this slide talking about the governance structure. A couple key players that I want to point out here is your Chief Executive Officer. Again, we're going to find this position in the C-suites. So the Chief Executive Officer is, what its name sounds like. They are the person in charge of the hospital. They're going to be over the day-to-day operations, and they're going to be the top of the leadership in that particular hospital setting. That Chief Executive Officer is going to report up to the Board of Directors. I think the book calls it the Board of Trustees. Means the same thing, just wanted to present both there. But the Board of Directors is going to have specific authority over strategic planning and budgets. So they kind of give their final say on the future direction of the hospital and how they're going to spend their money. Now, Board of Directors we typically see made up or comprised of members of the community so that we get a good representation of what it is the community wants. Chief of Medical Staff, or the Chief Medical Officer, the CMO is another one we're going to find in the C-suites. And they really work as that liaison or that go-between between the physician staff and the hospital administration. So they're kind of the throughput or the go-between right there. So we start understanding the licensure, certification, accreditation, descriptors for the hospital. It's important to note the difference between the three different types. So the first one is licensure. And these generally come down from the state government, and they're going to vary from state to state. The things that are required here in the state of Tennessee are going to be different if you go to like Virginia, Kentucky, North Carolina. But licensure from your state government is going to look at things like, are you up to building code? Are you up to sanitation code? Do all your nurses and therapists and your clinical staff have the appropriate licensures that they need to practice in the field that they're working in? Now, it's important to note here, and we're going to talk about accreditation here in just a second, but that facilities, they have to be licensed to practice as healthcare facilities, but they don't necessarily have to be accredited. We're going to talk about the difference right now. Certification and accreditation are two terms that are often used interchangeably. But understanding certification, you need certification as a hospital system to get reimbursement from Medicare and Medicaid services, and to have something called conditions of participation, meaning that you meet the conditions set forth by CMS to participate because you've met patient health and safety, different types of certification. When we talk about accreditation, these are going to be private standards set by different organizations to meet different types of criteria. So the one that you may be the most familiar with is the Joint Commission. Joint Commission has something called deemed status from Centers for Medicare and Medicaid. So a lot of healthcare organizations choose to receive accreditation through Joint Commission because not only can they get accredited by Joint Commission, which says that they've met the standards comparatively across the country, they've met the top standards to receive accreditation, but they also receive certification from Medicare and Medicaid because Joint Commission has something called deemed status from CMS. A couple other types of accreditation that you can receive. Remember, you don't have to have accreditation as a healthcare facility, but you do have to be licensed. Let's take, for example, the clinical, the pastoral department, education department at the Med Center. So this is a department that's accredited by the Association for Clinical Pastoral Education. They don't necessarily need accreditation to operate, but they've went out to seek accreditation, which says that they've met these standards or these criteria set forth by the Association for Clinical and Pastoral Education. Same thing with Wellmont, the Wellmont Breast Center right down the road here in Johnson City. They provide what can be considered, these potentially life-saving mammogram diagnostics for women. They've been accredited by the American College of Radiology. So again, you don't necessarily need accreditation, but you do need licensure. So just try to remember the difference between licensure, more from your state government, saying these are the things you need to operate, you have to be licensed, certification to receive reimbursement from CMS, and then accreditation saying that you've met certain criteria set forth by these different organizations. So moving on, talking about really the bottom line of the hospital in terms of its profitability. So overall, hospitals are breaking even right now, but the margins are improving. And, whether this is because of the Affordable Care Act or it's not, we don't really know yet. It may be a combination of a couple different things. But you can see, total margin kind of took a hit. The overall profitability of the organization kind of took a hit right here in 2008 when we started to see the inklings of the recession. So we saw a dip in operating margin as well. But operating and total margin back on the rise. So they're operating about a 5% margin or 5% profitability. So overall profitable. Breaking even right now, but on the uptrend. So even though we have this profitability with a couple of hospitals across the country, we still have about 1 in 4 hospitals are going to be operating in a deficit. We typically see these in more of our rural areas, so about 25% are operating in some kind of deficit. But look here, if you look at negative operating margin and total margin, so it corresponds with what we just saw in the last graph. Around 2008 we saw a dip, so we would see an increase here in hospitals operating in a negative total margin, negative operating margin. But since 2008 it's been back on the decline, but still we're seeing about 25% or 1 in 4 hospitals operating in that negative margin. So how the ACA has really affected hospitals and the hospital structure. We have a lot of more physician-owned hospitals. We looked at the graph a couple slides ago that saw the uptrend on private for-profit hospitals. But the ACA has come in and said that there are to be no newly opened physician-owned hospitals, and that those physician-owned hospitals that are in current operations right now, that they cannot expand their facilities unless they get explicit backing from CMS. So CMS saying, yes, you can expand because these services are needed. But newly opened and operated physician-owned hospitals are prohibited under the ACA. Non-for-profit hospitals, they've been charged more now that we're moving and shifting more towards population-based healthcare. They've been kind of charged with assessing the health needs of the community that they serve. So they've been mandated by the Affordable Care Act to go out and assess their community that they serve every 3 years, see what the major health threats are in that community, and start to create and come up with action plans to meet those needs. Now, if community hospitals or non-for-profit hospitals do not conduct this community assessment, they're going to be taxed a penalty of about $50,000, which you think for the bigger hospitals it may not be that much of a hit, but if you think of our more rural hospitals, which we know about 25% are operating in a deficit, $50,000 can be a big hit to more of our struggling hospitals. 2, for nonprofit hospitals, they're now required under the ACA to kind of have these policies outlined for financial assistance, and they've also been limited in the collection actions that they can undertake against patients who owe their hospital bills. So they have kind of restrictions on how they go about collecting on patient bills. So a couple key points to just kind of point out here from the overall lecture. Inpatient facilities, the main difference between them and outpatient, they treat based on an overnight stay of the patient. 2 main inpatient facilities that we have, hospitals, which we talked about in length today. Another one that we didn't touch on yet are nursing homes, but we're going to be talking about long-term care here in a couple weeks. So we'll talk more about nursing homes when we get to that point. And then two, we talked a lot about expansion and contraction of hospitals, and a lot of this was brought on by government policy. So we had the Hill-Burton Act in 1948 that caused the expansion. We had a change in reimbursement structure with prospective payment systems, and then the Affordable Care Act, which can be tied to some contraction in the hospital setting. And then we talked kind of about the distribution of hospitals across the country, with the most being private, non-for-profit community hospitals. So guys, I hope you guys have a really great spring break. Be safe out there. We'll see you back when we come back March 13th. Remember that we will not be meeting in class on March 13th. We're going to be meeting at the Mountain Home Museum. On the VA campus, there's a map that has been uploaded to D2L. So if you have trouble locating it, feel free to email me and I'll be able to point you in the right direction. But when you get to the VA campus, if you'll look for the building with the clock tower, if you'll go in on the left-hand side of that building down 4th Street, you'll be at the Mountain Home Museum. So we'll see everyone on the 13th. And again, you guys have a great spring break.